Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric Kelly. Today, I am with Dr. Ella Corrick. She has an MD from Oxford and a PhD in pediatric clinical pharmacology from Nottingham. Ella, welcome back to the program.
Thanks very much.
So you've been on the podcast before, but this is the first time that you have the full spotlight. Tell us a bit about yourself and what you're doing.
Thanks. Well, I'm a family medicine doctor by training, but I actually do most of my work in the emergency department now. I work as a family medicine doctor or GP in the Outer Hebrides 1 day a week, and then I also work in a Highlands emergency department in Scotland, which is 2 or 3 days a week, as well as doing my academia with Quorum.
So you do a bit of pre-hospital, you do a bit of A&E department, and you're also in very austere environments as a long-distance marathon runner, as well as being on the NHS ambulances. Tell us a bit about that.
Yeah. So I also respond as a volunteer for Basics Scotland, who essentially provide doctors, paramedics and nurses to the ambulance service as people who can be on call from home or on call from their workplace if their workplace is particularly remote or rural. And I also volunteer with local mountain rescue team. I recently joined the local team. I used to volunteer with the Hebrides Mountain Rescue Team out on the Outer Hebrides, which is a pretty cool place to be. And then, as you say, I do some long distance running. I'm very slow, but I can keep going. And I would say as time has gone on, I've become increasingly conscious of bits of medical kit that I want to have in my bag, even if I'm running a race. So I've recently acquired a cell AED, which are the really small AEDs.
Nice.
So even if I'm running a race, I've decided to have that in my pack just because I think I'd be very annoyed with myself if I come across a fellow runner and I'm the person who's within 3 hours of them and I don't have anything with me. So yeah, I hope I never end up doing pre-hospital care when I'm recreationally running, but definitely conscious that's a possibility too.
That's impressive. So you have an AED. The cell AED is super small. I've got one in my computer bag, but you're carrying. So I'm curious, what precisely is in your med kit that you're carrying on long distance marathon running?
It's and I think if you asked 10 different doctors or paramedics the same question, everyone's going to have things that have just stuck in their head from particular incidents where they wish they had something or a particular imagined scenario. So I'm not claiming that my kit covers all eventualities by any means. I essentially carry a cell AED, personal blister care, so a scalpel, some alcohol wipes and some good tape because I'm not attempting to do anything fancy. Pen frocks,
Nice.
in case somebody gets a very painful injury, and then plenty of ways to stay warm, hydrated, and full of sugar.
So you have a blister kit, an AED, and a green whistle for pain.
Yeah.
Brilliant. No ketamine or anything like that.
Not when I'm running.
Yeah. So I'm curious. As a Green Beret, we know blisters very well. So I've got my special way of dealing with blisters. I'm curious as a doc, how do you treat a blister? Do you cut it? Do you lance it? Do you put a string through it? Do you glue it? What is your weapon of choice?
It will depend on my patient. So for somebody who wants to continue running or stay in the field, my personal approach is clean the skin, lance, drain, and then tape, and try and just tape so that it's completely adhered, closed, and hopefully both doesn't reaccumulate and no longer has any opportunity for friction. On the other hand, if my patient is a casual walker who's not going to go hill walking again for 2 weeks, I would recommend not lancing it and just leaving well alone because they're better off slightly limping and reducing the risk of introducing infection. But definitely if I'm planning to still be running the next day and the next day, or I've still got 20 miles to go that day, I'm going to clean, lance, tape, done. What do you do?
Yeah, it's a very good question. I'm a fan of benzoin tincture. So on this side of the pond, it's Friar's Balsam, I think. And it's just this really sticky alcohol based, it's basically skin glue. And my favorite on being in special forces teams was to use a sterile needle and drain the bubble, and then fill a syringe with Fires balsam or benzoin tincture, inject it back into the collapsed, and so it's alcohol based. So you imagine the pain, but after about 20 minutes or 20, oh good God, 20 minutes, 20 seconds of lots of very uncouth words coming out of my mouth, the pain goes away, and it glues the top of the blister to the raw meat.
Yeah.
And then it's painless. And then of course I'll still do a donut dressing, and so to keep the pressure off of that wound, because it is a wound. But I'm not a fan of taping it unless it's hot spots. Taping hot spots, of course, but for an actual wound that or a blister that I'm not going to pop, which is rare, I would do the moleskin donut around it to protect it.
Yeah.
And the string through it, all that other, it just doesn't work. So your method, without using benzoin tincture, is continuing to be painful until they run on it enough that your mind kind of numbs the pain.
I think as long as you address it reasonably early, so that the roof of the blister is still flexible skin, it's not just dry, hard, dead skin. That usually adheres quite nicely to the raw flesh underneath. And then as soon, it's the same as a burn. As soon as you've prevented there from being contact, friction or air, then usually the pain goes. So usually I find when I've done it for myself, if I've lanced it, as long as I can get that adherent back tight over the raw skin, it usually isn't painful. And I'm aiming to make it a really small hole as long as I can drain the blister. So I don't usually find it painful. But on the other hand, quite often you've been on your feet long enough, everything hurts anyway. So kind of feels like it's all just part of the milieu by that point.
Yeah, that's what the Penthrox is for, isn't it?
I've seen ultra runners smoking while running ultra marathons, but green whistle's the next step.
Yeah. So yeah, I've only done long distance stuff with a big backpack on my back because it was a job. I couldn't imagine doing this for the crack leg.
I actually went and did one last Friday, just spur of the moment. The narrowest crossing coast to coast across Scotland is only about half an hour south of where I live. It's from a place called Ardguy to a place called Ullapool, and it's about 35 miles, or just over 36 miles, as I found out to my dismay when I'd sped up thinking I only had a couple of miles to go. So I went and ran that on Friday. It was good fun.
No, is this on the road, or is it a footpath, or is it what are you running on?
It's quiet country roads for the first sort of 4 or 5 miles, and then it turns into sort of partially gravelled tracks, and then just into footpaths as you travel east to west.
And is Tom following you in the car, or is he at home just hoping for the best?
I texted him when I got halfway to give him a plus or minus 15 minutes ETA, so he could meet me at the finish for some fish and chips.
Yeah, definitely. Fish and chips and a big pint would be well earned.
Exactly.
Brilliant. So you're on the mountain rescue team as well. Tell us about some of your casualties. What's the longest you've had to treat someone pre-hospital, or what are you normally seeing in a mountain rescue team as a doc?
Well, so I've worked with 3 different mountain rescue teams. I'm very new to the current team. Prior to this, I was with HEB MRT, who honestly the majority of call-outs were searches for missing persons. And because all of the Hebrides are very rural, occasionally that would be a road traffic collision and the driver's not found in the vehicle. So often you'll be searching, hoping and not necessarily expecting to find someone because you're hoping they've taken themselves home. And then before that, I was with Derby Mountain Rescue Team. And for those who know the UK, the common joke for Derby Mountain Rescue Team was that we didn't have any mountains, but we had close access to some very, very walked hills. So most of our call-outs were for people who perhaps weren't very rugged mountaineer hill walkers. They were, families or older people who had just gone for a walk because the hills are so accessible, and either had inadequate gear and found themselves suddenly in the dark, broken ankle halfway up a hill, or something along those lines, and actually not uncommonly had medical emergencies like an MI or suspected MI when they were out hill walking. The longest I've ever cared for a casualty, there's certainly some long carry-outs and walk-outs with mountain rescue. Where I am currently, our patch is very, very large with poor road access to quite a lot of the hills. So you might expect quite a long carry if the weather means the helicopter can't get in. But probably, in all sincerity, the longest I've had a casualty was very, very minor. I went on a small dog sledding expedition in Norway, and it was just a few days. But we got blizzarded, fortunately, when we were close enough to a shelter. So we were sheltering from this snowstorm. And one of my fellow colleagues just had a minor soft tissue infection in one of their hands from actually probably a blister. And fortunately, it didn't really develop into a septicemia or anything. But I was keeping an eye on her for 72 hours. Meanwhile, the main casualties were progressive increasing numbers of hypothermic dogs that we were bringing into the shelter, rewarming, feeding up, and then swapping back out with their teammates.
Wow.
So mostly it was looking after hypothermic dogs for 72 hours.
And do they have dog hypo wraps, or how are you keeping the dogs warm?
For the most part, because most of them are Arctic Huskies, so they're crossbreeds that are, absolutely built for the weather. Most of the dogs curl up in the snow settles on them, and our biggest job is just clearing snow from their airways and just leaving them alone in the snow, and they're beautifully insulated in their own snow hole, effectively. So we were going out sort of every couple of hours to check on the dogs to clear their noses, but some of the smaller dogs and early on, if the snow was melting onto them once they'd got wet, did start to get cold, and we were just bringing them in, and we had I can't remember if I think we had a fire, an open fire in the shelter, so we were just rewarming them with our own equipment and in front of an open fire, and then giving them a meal with hot water. And then once they'd had a few hours of being completely back to normal, we took them back out in the snow. It was still actively snowing, so they would curl up and then hopefully create their own snow hole.
So you're in some sort of hard structure. You're not in a 8-person bothy shelter.
Exactly. We were very fortunate that because we'd hit a patch of unexpectedly soft ice that prevented our progress that day, and we'd passed this hard structure about 15, 20 miles earlier, maybe a bit less. And we decided to just go back to the structure. The organizer of the expedition hadn't been checking his sat phone, but we got back and we just set up. We had a big shelter for all of us that we were sleeping in. We weren't planning to use the hard structure. Set up our tent outside. He still didn't turn on his sat phone, and we got woken up when the tent blew off us at the beginning of the storm. Got into the hard shelter, sorted ourselves out, gathered any kit that we could before it blew away. Quite a lot did blow away. He then turned on his sat phone and had the message from his wife warning him about the storm.
Wow.
Yeah. So it was quite lucky.
So normally, are you carry an 8-person bothy that then you put over the casualty and 2 rescuers, and to keep everyone warm whilst you're working on them?
In my personal kit, I carry for mountain rescue a 2 or 3 person emergency bothy, but the team has an 8-person. But the 2 or 3 person one is quite useful if you're in a hasty party, because obviously the smaller space warms up quicker. So actually, if you get that over yourself, you're usually with at least one buddy, and the casualty, 3 people warms it up incredibly quickly.
So that leads me to the question, what is the best way to warm a casualty in the mountain?
Well, direct warming with heat packs is definitely useful and has a role. So our team carries, as I say, the emergency shelters. Every team member is expected to carry one, as well as there also being a team one. So preventing further cooling, especially in Scotland from rain and wind, ideally getting the casualty into some dry clothes, but that's not always feasible. We carry heat packs that we apply to the core, and then we get the patient in a vapor layer and then further insulating layers. And the vac mattress, which we generally use as part of our packaging onto a stretcher, is extremely insulating conveniently. So those are the kind of steps we're using in mountain rescue Scotland, and then try and get them off the hill.
Nice. The vac mat is definitely the best option out there, but when you suck all the air out, is it still going to
Hmm.
insulate as much without the air?
Less so. So it depends on your patient's injuries. If they don't need immobilization, it's both comfier and more insulating if you leave air in it, but you obviously need it to be rigid enough to give a little bit of structure, and hopefully your patient's well strapped in, but it's nice to have sides so they don't feel like they can roll out of the stretcher.
And do you have a professional warming bag, or are you using Mylar bags or Blizzard bag, or what's your weapon of choice?
We have the bags, but Tom, who, as you know, is my husband and other half, who's also been on this podcast, has recently bought some of those uh, magic warming blankets, and he started carrying those and has tried it out a couple of times in anger now. And I wonder if we are going to start moving towards those. Um, but at the moment, no, we've just got blizzard bags.
Getting the casualty off the mountain, are you having a 16-person carry, or do you have a bike's tire with a Stokes stretcher, or what? How are you getting them? Are you just waiting for the heli?
We have got generally 16-person carry effectively. Um, and my previous team had the wheel add-on, but we don't have one. I think the terrain, the problem in our area, and it was the same in the Hebrides, is that there's actually very few walking paths. It's not there's almost zero footpaths in the hills, and then the paths that people are following are essentially deer tracks, and most of the terrain is either peat bog or gorse and heather. So
Mm.
wheels are completely useless. So it's generally a carry, and then if the weather allows and it's a significant carry, then ideally a helicopter.
One of our graduates of our paramedic program has created a pole system. It's called the Valkyrie Extraction System, where it's basically just a long pole with an
Mm.
enclosed patient casualty bag that's strung over between two shoulders. Would that
Mm.
would something like that be helpful for you guys in the bog, because you're otherwise you're having a normal stretcher with four people carrying it, and then you're going to twist an ankle, you're going to turn there's going to be
Mhm.
injuries. Would a big
Mm.
pole system be useful for you?
I wonder. That's a really interesting question. I mean, team equipment's always slow to change because your vehicles are set up to carry the kit as it is and all the rest. But that's a really interesting thought, and you're absolutely right. Especially when you're on a little deer track that provides some footing, but as soon as you've got four people on a stretcher, either two people or no people are actually on the area with decent footing. So yeah, that sounds. I've never seen that. That sounds really interesting.
Yeah, I was at the Liverpool School of Tropical Medicine on a course, and he popped in because he's close by, like, and showed the system to me. It's quite clever in a situation like
Hmm.
that. It I don't know, maybe it would be easier, because every time I've been in a mountain rescue situation with teams, it's the 16 people rotating in carrying
Hmm.
a
Yeah.
normal four person stretcher, which is no trail is. I mean, everyone's trail is basically wide enough for 2 feet, and now you have
Yes.
two people side by side. It's a bit mental. So
Yeah.
so the bike Stoke stretcher, or something like a single pole system.
Yeah, no, that sounds great.
So you have recently joined the college. You are on the doctoral team with your PhD from Nottingham.
Yep.
You're using that as and mentoring our doctoral students. Tell us a bit about the DHS. Tell us how you would like to improve it, or what direction would you like to take the doctoral faculty of the college?
The doctoral programs are doctoral in health studies, and it's an online PhD essentially. And so, like many online PhDs, and there are some really long established ones, especially in the UK where we've got the Open University, has been running the same structure really. It has quite a lot of talk components, but is still, at the end of the day, a PhD program, and students are expected to generate novel research and a thesis at the end of it. The, I guess, flavour of it that's different in Quorum and compared to other universities, and the reason why people might choose it is because of the college's focus on austere and remote medicine. So hopefully the areas of research are going to be focused on austere and pre-hospital care. And because Quorum already has very international faculty and being online can attract international students, it's hopefully an opportunity to explore the different solutions and approaches to austere medicine in different environments and the shared learning between different environments and different countries. The things that I'm hoping for in the program is mainly comes out of that. Actually, it's really interesting. Anytime people from Quorum come together, like at the MIM conference recently, the interest for me comes from people who work in such different environments, but they're having to solve the same problems, and you learn a lot from the different solutions people come up with, and often there's convergent evolution and people are doing the same things in different countries. So hopefully through the international cohort in the doctoral program, I'm expecting to learn a lot from the students. Hopefully they'll gain a lot from the program as well. And already kind of expecting and setting up for students to collaborate together, not necessarily collaborating on their own research, but forming their own community. So they generate out of it, or they come out of the program with this network of people who are like-minded but working in really different settings. And I think all of us will gain a lot from that, and that's going to be really exciting actually as a way of working. And there's always really exciting people to work with through Quorum.
Yeah, we have a cohort going through, the first cohort to go through our DHS system. And at the moment, where the feedback from the students was to redesign it a bit. And we have done, or we're going through that process. What changes would you like to see with the DHS, or what direction would you like that particular doctoral program to go?
Well, there's a couple of smaller structural changes that we're making, which maybe aren't super exciting, but hopefully are going to help students get more as they go along. I think there's always a risk if you have taught components before the research component, that the taught components, and I'm speaking from experience where there were some elements of this in my own PhD, can feel a little bit like a tick box exercise that you have to get through to get to the kind of meat of the PhD, which is your research. And so we're making it so that any assignments as you go through the taught work very clearly give students an opportunity to build towards their own research, develop their research interest, and start fine-tuning their ideas for their project. For example, we've recently reworked the research methodology module, and so that the assignment that come out of that are an oral presentation, which hopefully gives students some practice in a very low-threat environment at something like an oral defense to discuss literature review in an area of their interest. And then the written component is to produce a research proposal, which hopefully will focus their minds as they're studying research methodology to both understand something well enough to actually be able to plan towards doing it themselves, and to critique the different options in figuring out what would work to answer a research question that they're interested in. And also, hopefully, what they come out with might resemble something they end up approaching as their ultimate research question. And in my experience, the more writing you can do as you go along, the better. The people who really struggle to finish are people who did a ton of work in the first 3 years of their PhD, but they hadn't done any writing, whereas people who wrote chapters as they went along have much greater likelihood of successfully completing their PhD, which is what we want for all students. On the more kind of exciting and interesting side is the fact that the faculty is expanding, and we've got people who are really interesting and exciting, hopefully joining the faculty, who are people I'm really looking forward to working with. And we are hopefully going to incorporate more opportunities for collaborative sessions like workshops and seminars, where we'll have several members of faculty as well as all the students present, which just gives you the opportunity to pick brains of people who've got really interesting backgrounds, deep research backgrounds, and very broad research interests. So watching the kind of faculty expand, and then also as the student body expands, all the people who are involved in the program have got their own areas of expertise. And genuinely, I know it can sometimes sound a little bit pat to say, but you learn so much from students as you work with them, because these are people who are coming from professional backgrounds and coming from places where I haven't worked, and it's really, really interesting talking and learning with them.
I do. It's one of the best part of being an academic is seeing what the students are doing and then learning as they learn.
Yeah.
What other postgraduate programs would you like to see the college do?
That's a really interesting question. Well, I think some of the established programs, it's more about them growing and maturing with time, because as students graduate from the programs, we gain experience in the way the program ran, and I guess it's always a process of remodeling and building. I'd quite like to see there being more cross-pollination between the different programs. So we've got the Masters in Osteocritical Care, and that can overlap with lots of the learning outcomes in the doctoral program. And so having some collaboration between the programs, or at least opportunities for the students to work together, would be really nice. New programs, it's funny, you could ask me on different days and I would have hundreds of ideas, but probably areas in mountain medicine and mountain rescue medicine, areas that would be really interesting for Quorum to go into. And I know we already have members of faculty who work in some real centres of excellence, like working with Air Zermatt. So bringing in learning from centres like that, so that people who are working in smaller teams or in less long established settings, learning from places that have been, really leading the field, that would be really exciting.
We already have approval from ICAR to run a DIM, a diploma of mountain medicine in
Oh, amazing.
and as well as the ADIM, the African Diploma of Mountain Medicine, and we already have the AHEMS
Oh,
module
wow.
up and running and accreditation. Would that be an option to upgrade into a Master's of Mountain Medicine?
Yeah, I should think so. And I think that would have lots of people interested as well, because, there's some really well established DIMs, and there's some that are, I suppose, they're maybe more early career medics who are interested in expeditionary medicine and things, go on. And then when you're slightly further along, having something that has the opportunity for more depth or to pursue a particular interest, that would be great.
I look forward to seeing what your department can do with this, so that the postgraduate faculty getting together and possibly putting that together. But let's get the ADEM up and running first, and then we can look at upskilling into that. So the only thing keeping the college from upgrading to a full university is the lack of a developed research component. How do you see us doing that? This is the last pin in the puzzle to get us into a full university status. So how can we increase our research capability and meet this requirement?
Well, I think it is in progress. I know we've recently joined the European Prehospital Research Network, and so that's going to they'll have projects that they'll want to draw us into, and hopefully it also gives us, again, a pool of minds that we can draw into any areas of research that the faculty want to pursue, and not only minds but other settings and pairs of hands as well. So that's definitely an avenue we've already started down that path. And as well, the postgraduate students are excited and interested and keen to be generating their research, and that's often going to be the most productive part of the university, I suppose, hopefully, ultimately. And we've got, from the MIM conference that ran recently, we had a session there about publishing in academia. And out of that was run by 4 of the faculty. Out of that, I know just Tom and myself, who are 2 out of the 4, have received several emails from people who've got research. I suppose I don't want to frame it as research and make it sound like they've been doing research without being publishing and transparent. They've got data from where they're working, and they are innovating in their services. And I think they've been maybe a little bit inspired to actually recognize that what they're doing would be really valuable research, and it would be more valuable if you share it with the scientific community. And so we've had several people contact us asking, how do I turn this innovation we're already doing into actually, proper research and examine what we're doing and study what we're doing. So I think we're starting down that path, and as well as more and more faculty join, everyone brings with them an area that they're already studying, and that hopefully is going to transform into Quorum producing this research. And so yeah, I think it's happening.
One of the requirements is an institute review board. Should we create our own IRB in order to support our homegrown research?
I think we should have an institutional IRB. I think we also should be getting external reviews as well. Clearly, if it's any research that involves patients, we're always going to need regional review in the area where the research is being done as well. But I think if we have it within Quorum as well, first of all, it allows for an early review of work to make sure that the project is formed well. And part of the purpose of ethics review, it's not just, clearly it has very important roles in safeguarding ethical practice, but it also means that it structures research so that it's done in the most, I'm coming from my background in rational prescribing, in a rational way. So you want to do research that's actually modelled to answer the question it's looking to answer, because it can't be ethical if it's completely ineffective. And so having our own local IRB to help, especially early career academics, remodel their research design early to make it as good quality research as possible, and then going to external review for a second look and to make sure we've got really robust assurance processes. I think both of those have important roles.
Ella, my final question for you is this. What advice do you have for the newly qualified doctor, nurse, or paramedic who is interested in austere medicine?
From my own experience, and this won't apply to everyone, but personally I think taking opportunities to work in new places can be incredibly valuable. And having done that early in my career and worked in lots of different settings, 3 different mountain rescue teams, it exposes you to more and more different ways of doing things. And early in your career, certainly my brain is trying to absorb ways to do things, and so I learn, this is the way that you do something. And you join another team, you're like, they're doing it the wrong way. And then you very rapidly learn actually that their way might be better in their setting, or maybe there's ways that their way is worse, and you can nudge them to improve. But until you're exposed to lots of different ways of working and different problem solving, you limit yourself to learn one way, and one way isn't always the best way. And so I've learned the most by taking opportunities to work in different places and with different teams. And all the other piece of advice I would give, again, it's worked for me, I'm not saying it would work for everyone, is to follow your interest. And if a job opportunity or a workplace excites you, then even if it's not the way you imagined your career going, then follow that excitement, because eventually that ends up molding a career that excites you.
Dr. Ella Corrick, thank you for chatting with me today. You're a welcome member of the faculty, and you're already making the college better. So thank you for your time and influence, and I look forward to seeing what you can do.
Thanks very much for having me.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.